The new guidelines have introduced very important new concepts. The first concept is the use of diuretics. Diuretics should be used throughout the patient journey and modulated at each visit. And this is a very important concept because diuretics may improve exercise capacity and reduce the hospitalization rates. Then the mainstay of treatment must be ACE inhibitors, beta blockers, and ARBs. It is important that we can start ACE inhibitors and beta blockers together, but we cannot start beta blockers before having started an ACE inhibitor. If patients are still symptomatic after treatment with ACE inhibitors, beta blockers, and if needed, diuretics, then we need to add an MRA and up-titrate the MRA gradually. Then if a patient is still symptomatic, there is a possibility of implementing a therapy with either Entresto or ibabradine. The only problem is that these two treatments should not be seen as alternative. They are complementary treatments. They can be used together, they can be started together, and they can be implemented at any stage or in symptomatic patients. There are some limitations for both of the drugs. The limitation of ibabradine is for patients with atrial fibrillation or in sinus rhythm with a heart rate less than 70 beats per minute. Patients with Entresto or sacubitril valsartan are patients have to be symptomatic, have to have a reduced left ventricular ejection fraction, elevated natriuretic peptide levels. Now, if these treatments fail, then we can add digoxin, or we can refer our patients for LVAD or cardiac transplantation. What is important is that we've also recognized the importance of comorbidities. Amongst these comorbidities, there is COPD and diabetes. And we had a very good news in the past few months from the diabetes world with a new drug, empagliflozin, that has reduced hospitalizations for heart failure and mortality in patients with diabetes and cardiovascular disease. So the recommendations for patients with diabetes is to be careful with some of the drugs like glitazones. We should implement therapy with metformin, but also we should implement the therapy with empagliflozin that has shown to reduce mortality and morbidity. Of importance is that all patients with diabetes and heart failure or at increased risk of heart failure should be taken care by the heart failure team rather than left to other specialists.